All right, we're gonna get started just as you're walking in back to your seats. Good? 30 seconds? Okay. All right, welcome back everyone. I hope you had a chance to caffeinate and maybe quickly connect during that short break. So to kick it off, we have our first panel session, Accelerating Connected Care, Innovation, AI, and the Future of Primary Care. This session will explore how digital tools are helping to relieve pressure on primary care systems and ensure clinicians spend more time doing what they do best, caring for patients. This bilingual panel will feature Infoway's AI Investment Program, which is, by the way, one of my very favorites, and you've already heard a lot about it. So to lead this important discussion, please welcome our moderator, Rita Jervis, Vice President of Regional and Vendor Engagement at Canada Health Infoway.
Thank you, Krista, and good morning. So welcome to our session, I'll say it again, on accelerating connected care, innovation, AI, and the future of primary care. And a warm welcome to our panelists. It's my absolute pleasure to introduce Dr. Rashaad Bhyat, the Senior Clinical Leader at Canada Health Infoway, Marc-Nicholas Kobrynsky, Deputy Assistant Minister, Directorate General of Strategic Planning and Performance, Government of Quebec, and Ryan MacNeil, Project Executive and Director, Digital Strategy and Governance, Department of Health and Wellness, Nova Scotia. So if I might set some context for today's discussion. AI Scribe solutions have only recently entered the primary healthcare space and have created quite the buzz as a tool that truly reduces administrative burden. But AI Scribes are more than a time-saving tool. By embedding AI solutions built on national data standards into our health system, we are creating a scalable foundation for more interoperable and connected care across the system. Canada Health Infoway's National AI Scribe program, as you've heard, was launched this past year. The speed and breadth of its uptake across the country and the impact it's already having exemplifies how a collaborative, pan-Canadian initiative can deliver near-term benefits to clinicians while paving the way for long-term system transformation. So today, we'll hear about Infoway's AI Scribe program. We'll explore how AI Scribes are transforming primary care practice, and we'll look at where we go next with AI technologies as we continue advancing the digital maturity curve, or the maturity model for connected care. Okay, to get us started, I'd like to invite Rashaad to tell us about Infoway's AI Scribe program, how it was designed, how it's being implemented, and most importantly, what we're hearing from clinicians on the ground. Rashaad, over to you.
Thank you, thank you, Rita, for the kind intro. And hello, everyone. My name is Rashaad Bhyat. Il y a un peu d'ironie ici. J'aime beaucoup le papier, mais c'est une conférence digitale. Bonjour et bienvenue à tout le monde. Je suis fier d'être ici pour cette présentation avec Marc-Nicholas et Ryan. And a huge thank you and shout out to our events team. And our communications folks for putting this all together. Infoway's programs and activities often occur in the background and rely upon partners from across the country who do a lot of the heavy lifting. I will be providing you today with some reflections from the physician perspective, in this case on AI, innovation, and the future of primary care. I just want to note that Dr. Ed Brown is hosting a very interesting clinician-focused panel right after this one that I would encourage you to stay for and attend, which delves deeper into the workflow conditions that prevent physicians and other clinicians from participating to their full potential in our system. So this is me on a typical day in the clinic in our current state of disconnected care. I'm constantly chasing down results. I have multiple logins for different systems. The information from my staff and that we seek is never in one place. We have lots of e-faxes incoming and outgoing. It's a bit of managed chaos, and that's on our side. Imagine for the patients who are trying to also navigate this scenario. And I have a relatively small practice. It's much more challenging for family physicians and NPs who are working in very large practices. If this is our current state, the question is, can trust be rebuilt in a meaningful digital transformation in Canada that truly engages physicians and other clinicians? If there's one thing that you can remember from this talk, it's really that through clinical engagement and co-design, yes, it is possible, and that AI-powered tools may be a promising start. So this won't be news to the audience, but physicians and other clinicians now practice in digital environments, reflecting a massive system transformation over the last 20 years. However, digital health in Canada has evolved in a chaotic manner, with many challenges downloaded upon physicians and other clinicians, frequently without our input, with negative impacts upon mental health, patient safety, and equity. Canada is facing multiple large challenges in healthcare exiting the pandemic, including clinician burnout linked to the administrative burden, the interoperability gap, and patient safety risks due to the interoperability gap that has been highlighted in reports such as Interoperability Saves Lives and by our task force report. And you'll hear a lot of similar themes echoed from Michael's talk and Elizabeth's excellent talk just before this one. Now, just a little bit of background and context and data. The data from the following slides helps to paint the picture further and comes from our 2024 physician survey results, a partnership between the Canadian Medical Association and our Infoway research analytics team. This is a good news slide. 95% of physicians say they use EMRs or EHRs to enter and retrieve clinical notes, an increase from 87% in 2021. However, the picture gets a little murkier. This is the so-called pajama time finding. Average time spent on an EMR after a typical workday by physicians who use an EMR was 107 minutes, and 51% spent 2 hours or more. This is an unsustainable situation that is driving family physicians to retire and making it challenging to recruit new physicians and nurses to primary care at all. Nearly half of physicians, 44%, report feeling burned out to some extent, with 5% feeling completely burned out. Again, an ominous finding in the context of mounting challenges with difficult-to-use digital tools and low levels of interoperability. And all of this was the context that led us to a key thought leadership activity, the Digital Health Interoperability Task Force. Burnout and administrative burden linked to the current state of disconnected care had not been explored in depth through the physician lens at a national level. So a partnership of Infoway and the 3 leading national physician organizations, the CMA, the CFPC, and the Royal College, brought together 17 senior physician leaders from across the country with experience and understanding of the digital health landscape, along with nursing and patient representation. A huge thank you here to Dr. Ed Brown, the CMA, Aline is in the audience, and our secretariat team for driving this forward at every step. I was fortunate to co-chair the task force with Dr. Ogunbi from the Royal College. In summary, the task force had 3 goals. First, provide a physician perspective on the current state of interoperability or lack thereof in Canada. Second, stimulate approaches and innovations to overcome key barriers to physicians. And third, to ensure that the implementation of interoperability-linked tools is practical at the front lines of care. The task force released its recommendations and report almost 1 year ago today. And so here they are all on one slide. These 5 concrete recommendations outline tangible steps for decision makers to take. Number 1 is that we need a well-defined plan and must move faster towards an improvement in interoperability within 5 years. And all of you in the audience are part of this work today. Recommendation 2 is to accelerate policy and legislation to advance interoperability with critical support from provincial and territorial governments. This includes legislation to mandate the data and technology standards required to support clinical data exchange and transactions, as was envisioned in Bill C-72 and will hopefully be revived. It also includes a national framework for modern health data stewardship policies that Elizabeth alluded to and that Kai-Hai is working on. This must include as well formalization of Indigenous health data sovereignty policies as determined by Indigenous communities themselves. Number 3 is that you forgot about the docs. You forgot about workflow. Provinces and territories need to address the key barriers preventing physicians and other healthcare professionals from participating in health data interoperability initiatives by ensuring that health data solution deployments are co-designed with clinicians and that the administrative burden and cost of interoperability initiatives are not downloaded to clinicians. Recommendation 4 is that organized medicine must continue to be actively involved, playing an important role in providing guidance and support to physicians on interoperability through development of best practice guidelines and advocacy for education and training support. And recommendation 5 is that we must have continuous innovation through our R&D funding organizations, for example, developing new strategies and activities such as data standardization, curation, and report generation from EMRs, including leveraging AI tools that better support clinician participation and reduce our workload. And so this brings us to the AI Scribe Investment Program, which is one of our efforts to take action on the recommendations of the task force. We had hoped to reach, as you heard earlier, 10,000 primary care providers, including family doctors, nurse practitioners, RNs, pediatricians in the community, and we are well on our way. Infoway and our partners at Health Canada, provinces and the territories see an opportunity to both improve the administrative burden using a novel tool, AI Scribes, but also to advance better EMR data quality, standards-based interoperability of data, and improved analytics in primary care and beyond. And you'll hear a bit more about this in the talks that follow myself. So the vision here is really that our program articulates a vision of maturity of AI Scribes, moving from basic AI Scribes towards AI Scribes Plus, tools that not only assist with documentation, but eventually integrate with EMRs, help extract data from our SOAP notes in a standardized format, such as the patient summary. The data can then be used for other forms of data exchange and workflow, including filling forms, auto-population of referrals and requisitions, prescriptions, and more. So these next two slides really speak for themselves. The adoption and uptake of AI Scribes due to our program has surpassed expectations. We went from over 6,000 registered users in the first 48 hours back in June to more than 11,500 by the end of October, with over 8,000 live users and counting. From our initial pulse survey of participating primary care clinicians, findings are overwhelmingly positive and reflect findings in other studies from Ontario MD and Doctors of BC. 94% say AI Scribes save them time, 96% say AI Scribes are easy to use, and 98% would recommend AI Scribes to peers. I'm amongst the 98% that would recommend AI Scribes to peers. And so you can see these findings further reflected in the emerging evaluation results by our partners at the Weave Research Centre at Women's College Hospital in Toronto, Dr. O'Neill, Bhattacharya, and team. Clinicians are getting time back with resulting improvements in presence with patients and improved mental health. The impact on patients, similarly, is very positive and tangible. Clinicians comment on feeling, again, more present with their patients and feeling like the time spent with patients is a higher quality time. I noticed this myself over the past few months. I can really focus on the people right in front of me and not focus on the screen, even though I'm pretty good at typing. But anyway, there are still challenges, of course, and some potential for improvements, including the dreaded note bloat, for example. And so with the advent of game-changing technology in the form of generative AI, scribes, and more, we must continue efforts to make it easier for clinicians of all professional backgrounds to participate in a digitally interoperable healthcare system, enhancing patient safety and patient care, and simultaneously rebuilding trust in the system. Infoway and our partners, national, provincial, territorial, and Indigenous, are looking forward towards how our roadmap might be refreshed and how a roadmap can be built upon recommendations of the DHI task force to make this vision a reality so doctors and nurses and pharmacists of the future can walk into a clinic and interact with their digital tools the way we do with our smartphones. It's a three-layered cake, and it can't be accomplished without partnership. Stream 1 would see us aim to support the adoption of market-ready productivity tools for clinicians that leverage AI. Stream 2 would support and legislate interoperable requirements, standards, and specifications such as HALO, CAFEX, PSCA, CA Core Plus, CA CDI, and more. Stream 3 would continue to advance a national trust exchange framework incorporating privacy, security, and governance for the flow of information between digital health systems within regions and cross-jurisdictionally. And finally, with the right elements of trust, clinician co-design, and engagement, can we reach this near future state, this Zen-like state that we see on the photo in the image here? I think so. Scribes are just the beginning. AI-powered tools, including agentic AI, will transform much of the repetitive, low-value work that clinicians have to do but hate, and allow us time back to focus on the higher-value work that we want to do. But time will tell. And with that, I will pass the mic over to Marc-Nicholas. Merci.
Thank you very much, Rashaad, for that great overview and for grounding us in the real-world impact of the program. So now it's only fitting, since we're here in beautiful Quebec City, that we turn to one of our provincial partners who played a key role in this initiative. Quebec has been a strong leader in exploring the use of AI scribes in primary care and is now expanding its work to evaluate their impact on allied health professionals. Marc-Nicholas, the floor is yours to share Quebec's approach, early insights, and what's next in your journey.
Merci. Thank you. Bonjour tout le monde, ça me fait plaisir de parler en français ce matin, but I am fully bilingual. When the Q&A comes, I'll be more than happy to answer in English if that's the necessity. Now let me go to my presentation. So we'll be describing, and before we get, that's the rough plan, but I always just write a rough plan and then basically think of what I want to tell people when I'm sitting in front of them. So I have 10 minutes. Basically, these are the 4 things we're looking at. Facilitate the use of AI scribes in healthcare. And we've gone a lot... Pardon, voyez-vous, je reste en anglais, puis je lis en anglais. C'est incroyable, le français-anglais. On regarde beaucoup plus large que les médecins. Puis en fait, je vais commencer, avant de parler du plan, je vais dire une première chose. J'aimerais remercier Infoway, Santé Canada. C'est pas simple de partir ces programmes-là. C'est pas simple de partir de l'innovation. Ça fait un certain temps qu'au Québec, certains groupes avaient la velléité d'aller de l'avant, identifient l'intelligence artificielle, la connectivité et comme étant un élément majeur qui pourrait nous sortir du marasme dans lequel on est. Puis c'est difficile des fois d'obtenir du financement. C'est imbécile d'obtenir une oreille. Le financement, c'est pas simple. Vous le savez, ceux qui viennent du Québec, vous le savez, il y a des hôpitaux à reconstruire. C'est tout le même financement qui va dans le même fonds d'infrastructure, là. Fait que quand tu demandes du financement pour le futur, des fois on dit on n'a pas assez de financement pour le présent. Fait que là, tu te bats contre le présent, puis c'est difficile. Fait que déjà là, je voulais remercier Infoway et Inforoute et Santé Canada d'avoir permis d'ouvrir la porte et d'être capable de prendre cet agenda-là et l'amener plus précisément dans la province pour être capable de faire des démonstrations et l'importance que ceci pourrait avoir et le retour sur investissement. Parce que ma perspective personnelle, pas celle de mon gouvernement, mais en même temps, je suis Assistant Deputy Ministry en planification stratégique. C'est ma job de regarder un petit peu en avant. Mon évaluation de la situation, c'est que s'il n'y a pas une hausse de productivité significative, mais là, pas genre 10 %, significative dans tous nos systèmes de santé, de livraison de santé, le système va finir par s'effondrer. Et c'est un système qui, à mon avis, moi, j'y tiens beaucoup. Je suis très fier de savoir que chacun de mes concitoyens, qu'ils soient riches, pauvres, de n'importe quelle origine, puisse aller se faire soigner au même niveau que moi. Ça me tient beaucoup, ça tient beaucoup à cœur à la plupart des Canadiens. Mais il ne faut pas le prendre pour acquis. Et je crois que si on le regarde à plus long terme, il est à risque présentement. Et c'est des solutions comme ça qui ont un potentiel majeur de complètement transformer et qui ne sont pas particulièrement dispendieuses. Puis vous allez dire, fait qu'on parle, on parle juste avant, Rashaad nous parlait du programme spécifique MedAI, qui est très intéressant en lui-même, mais prenez ceci, extrapolez-le sur, moi j'ai 330 000 employés, là. J'ai 330 000 employés chez Santé Québec. Là, on parle de 10 millions, j'ai 10 000 médecins à peu près au Québec, là. Mais moi j'en ai 330 000 employés. Tu sais, c'est ce type-là et leur coût sur l'appareil public, sur les finances, mais aussi la productivité, mes listes d'attente, tout ça, c'est cette vision-là qu'il faut avoir pour le futur. Fait que justement, on est vocal, mais réellement, je remercie Santé Québec Inforoute parce que c'est eux qui ont donné une impulsion supplémentaire. En toute transparence, j'avais de la misère au ministère à trouver des fonds pour être capable d'aller de l'avant. Aussi, en parallèle, évidemment, on travaille pour que ces projets-là arrivent dans un framework, m'excusez l'anglais, là, pas complètement comme un cheveu sur la soupe, juste pas comme des outils technologiques que tu achètes, ils viennent de se placer dans un framework qui est de l'IA responsable, comment on travaille avec ces outils-là, comment on les apporte, comment on s'assure qu'ils soient utilisés sans biais pour les bonnes raisons. Puis, au départ, on avait fait nous-mêmes, dans nos équipes, on a fait une preuve de concept utilisant l'AMA, le open source de Facebook à ce moment-là. Puis on a fait notre mini home care avec des micros achetés nous-mêmes, puis tout ça. Puis tu allais sur le terrain et ça donnait déjà des résultats fantastiques. Puis on se disait, si nous, une petite équipe au ministère qui ne fait pas vraiment ça, est capable d'arriver avec ça, avec juste l'open source, on est capable de démontrer que le potentiel est immense. Et puis, c'est là que, justement, est arrivé les programmes d'Infoway. Et le premier programme était celui pour les médecins. Vous en avez entendu parler, j'en reparle aussi dans les slides. En toute transparence, puis je sais qu'il y a beaucoup de médecins dans la salle, ma première réaction, ça a été, mais pourquoi les médecins? Parce que les médecins, dans ma tête, c'est des travailleurs autonomes. S'il y a des nouveaux outils qui les aident à devenir plus efficaces, ils devraient les adopter eux-mêmes. J'ai dit, moi, j'ai tout du monde dans mon home care, en psychologie, en DPJ, qui sont mes employés, que je dois être capable de payer des outils pour eux augmenter leur productivité. Mais c'est correct. Dans le plus grand... On a été des grands fans du programme. On s'est assuré, nous, d'avoir une équipe à l'interne pour supporter, valider que les médecins l'utilisaient, faire des suivis auprès des médecins pour ceux qui ne l'utilisaient pas, pour dire, vous allez perdre votre licence, il y a des listes d'attente. On a été très agressifs dans... l'implantation du projet pour être sûr que chaque licence soit utilisée. Et nous, notre but original à la fin était, on va créer un masse critique, puis après, on ne sera plus obligé de s'en occuper. Une fois que les médecins vont être convaincus, que 30% des médecins sont convaincus que c'est ça le futur, ils vont se parler entre eux, puis ça va être le futur bientôt. On n'a plus besoin nécessairement de s'impliquer. Puis rapidement, on a placé, nous, notre tête à dire, la prochaine étape, c'est tout ce qui est les services sociaux. Puis je ne sais pas, je ne veux pas prendre trop de temps, mais si vous avez parlé des services sociaux, c'est catastrophique le temps qu'ils parlent en dossier. On parle souvent aux médecins, là, mais une travailleuse sociale, moi, j'ai passé 2 à 4 semaines sur le terrain, suivant les travailleurs sociaux, des ergothérapeutes, des gens de la DPJ. C'est la moitié du temps qui passe en paperasse. Fait que si vous êtes quelqu'un du gouvernement, dites-vous que, ou si vous êtes un citoyen, prenez l'argent qu'on met dans les programmes de services sociaux, enlevez la moitié, c'est ça la valeur que vous avez. Fait que pour nous, il y avait une urgence d'agir dans ce côté-là. On a 2 pilotes qui commencent, 2 pilotes significatifs. Parce que certains de nos établissements avaient déjà commencé des pilotes, mais à 10 personnes, à 5 personnes. Je ne suis pas capable, moi, de remonter ça pour dire, hey, voici le ROI. Je ne suis pas capable de remonter pour dire, hey, on a vraiment transformé une équipe complète, puis voici comment ça fonctionne. Et puis, on regarde, c'est ça, le home care en général. Puis, il y en a un là-dessus que je ne pense pas que j'avais mis, c'est ça. On regarde aussi des prescriptions. On est rendu là. L'idée d'avoir une intelligence artificielle qui aide les médecins à identifier les médicaments, les problématiques de médicaments ou les médicaments qui ont été trop prescrits. Other people have interesting things to say too. Fait que c'est comme vous pouvez voir, mais tout ça s'attache. Pourquoi, admettons, des prescriptions? Bien, parce que je regarde d'un côté, mes budgets de médicaments n'arrêtent pas d'augmenter. Je regarde mes études populationnelles au Québec. Le Québec est celui les Québécois sont ceux qui prennent le plus de médicaments au Canada. Puis, bien, je veux dire, les médicaments, à cause de la RAMQ, en grande partie, c'est le gouvernement qui finit par les payer. Fait que là, il y a toute cette question de est-ce qu'ils sont bien soignés? Est-ce qu'ils prennent trop de médicaments? Est-ce qu'il y a des contre-indications de ces médicaments-là? Puis pourquoi on prend tant de médicaments que ça? Bien, ça me coûte plus cher. Mais fait que puis là, je ne dis pas c'est quoi la solution finale, mais je dis, je veux fournir un outil d'intelligence artificielle qui puisse être rapidement identifié pour les médecins, quels sont les cas où il pourrait avoir des prescriptions qui seraient intéressantes. L'outil ne fera jamais la décision lui-même, mais c'est un outil d'aide à la décision qui vient aider mes objectifs stratégiques. Fait que vous comprenez, c'est pas juste ah oui, je veux que quelqu'un soit plus efficace dans la paperasse. Là. Il y a des objectifs stratégiques à travers le choix de certains de ces projets-là. Puis si ces projets-là arrivent, ils vont avoir un impact majeur sur mon bottom line ou sur la qualité des patients ou sur l'organisation des services. Nous avons reçu le programme chez nous si on regarde les findings, les initial findings du programme d'Infoway, très, très positif chez nous. Je vais me donner juste un petit peu de crédit parce qu'on passe en arrière puis on est sûr que, tu sais, moi, les médecins qui ne l'utilisent pas assez, c'est comme, hey, on va te l'enlever. Fait que là, tout d'un coup, on voit que l'utilisation augmente, mais ça marche vraiment bien. On a eu des petites questions au niveau du consentement, mais les DME avec lesquels ils sont impliqués, ont rapidement streamliné le processus du consentement, puis maintenant, je vous dirais, ça roule très bien. Évidemment, il y a certains secteurs qui fonctionnent mieux que d'autres, particulièrement là, les soins tout ce qui est dans un cabinet fermé fonctionne bien. Puis en fait, même certains des services sociaux, quand ils sont dans un environnement contrôlé, tu sais, le travailleur social dans un environnement contrôlé d'une GMF, ça fonctionne bien. Le travailleur social sur la route, chez le patient, ce qui est 90% de nos travailleurs sociaux, là, ça fonctionne moins bien. C'est effectivement, on a du travail à faire, mais on est extrêmement confiant que c'est là qu'on s'en va. Puis là, je veux rajouter, il faut qu'on aille là. C'est même pas genre, c'est pas qu'on sait, il faut qu'on aille là. On est rendu là. One minute. Fait que c'est sûr que nous avons, tu sais, c'est pour le gouvernement, pour ma direction, c'est clair que un des éléments de solution majeurs est l'utilisation d'intelligence artificielle, pas juste d'un niveau tactique, mais dans des projets tactiques qui apportent des gains opérationnels, des gains stratégiques. C'est absolument clair. Nous avons soumis notre premier plan sur l'intelligence artificielle, qui aussi l'encadre. Fait que c'est beaucoup plus facile. On a essayé de le garder léger, c'est-à-dire que c'est plus, tu veux faire un projet en IA, toi, quelque part dans le réseau, bien, lis ça avant. Applique ceci, puis on a 98% des chances que ton projet va être l'IA responsable. Puis, ben, je pense qu'on l'a dit, mais je pense qu'on en parle. L'IA, par utilisation verbale, est prometteuse pour transformer l'ensemble de la pratique. Merci beaucoup. Je serai disponible pour les questions.
Merci, Marc-Nicholas, for sharing Quebec's experience and lessons learned. Next, we'll hear from Ryan, who will share how Nova Scotia is leveraging AI Scribe technology to improve primary care delivery in primary care settings. Nova Scotia also participated in the national program, taking a slightly different approach and looking to take it one step further in its implementation and integration work. Ryan, over to you.
Thanks, Rita. I plead that someone hangs from one of these incredible chandeliers to distract from the thing on my face. But I'm humbled that by me just doing this, destigmatizes the conversation for men's mental health in Canada. So, thanks kindly to Infoway for having me, but most importantly, funding our initiative. We're really excited about the things that we're doing with AI Scribe. And I'm going to talk a bit, to Rita's point, about the programmatic approach we took in Nova Scotia with AI Scribe. You'd be much better off hearing from Kim Knox in PEI, who's the other jurisdiction that's doing this, but they're launching very, very soon, so hold on for that. Some context about Nova Scotia first that I think is helpful. So in Nova Scotia, we have 2 certified EMRs, which significantly reduces the amount of EMRs in our province, and clinical integration was deemed very early as a clinical requirement before we moved anywhere with AI Scribe. So that really helped our partnership approach. We also have health authorities that are nearing 50% of our primary care clinic. So clinics operated by Nova Scotia Health, which increases the amount of privacy, cybersecurity, things like that we need to consider. And another thing about Nova Scotians is that they're great, so feel remiss to not say that. Our programmatic approach, partnership was fundamental. I'm going to click. Oh, sorry. Yeah, I got it. Yeah. Partnership was fundamental. So, of course, Infoway, but as well, we partnered with Makata AI Scribe, an integrated solution with both of our EMRs in Nova Scotia. And we've taken a bit of a different approach with that program to actually partner with our clinicians as well. With our programmatic approach, we are doing provincial contracting. We have made it available and kind of stood behind one of our Makata AI Scribe through our privacy and cybersecurity components to make it more available and decrease that barrier for clinicians. We've also added some stipulations to be funded by the AI Scribe program. So for our 500 licensed users and physicians and nurse practitioners at this time, we're looking to expand that. We are funding it pending that they complete 3 necessary tasks. So for us, we added on for some of the evaluation questions to think about a little bit deeper about the implications in primary care access, delivery, what the implications are. But we have mandatory evaluation. So we're forcing that all of our participants do actually complete the pre-implementation 3 months and 6 months evaluation so that we're getting that pulse. We've also standardized some of the terms in the contracting as well as supported them through the actual integration process, so reducing that barrier and burden on our clinicians. As well, we have a mandatory hours training session. So we're having every provider come to a training session led by Nova Scotia and Makata Health to talk and educate them on our policy and our expectations from Department of Health and Wellness side. And then, of course, where change management resources are lighter on this one, we want to ensure that people are getting off on the right foot and getting that in-depth training. Another thing we've done is we've made this all available on our provider toolkit. So we're really working in Nova Scotia to centralize the resources for clinicians in a provider toolkit and start to add all of our program supports and things like that there. You can see that online now, so lots of information about the program there. Newsflash, we are nearly a month into our program, and AI Scribe's here to stay. Some iteration, we are doing AI Scribe forever. With that, for me, it feels counterintuitive that we expect our frontline clinicians to educate every citizen of Nova Scotia what AI is every time they have a 15-minute appointment, which is why we've taken a bit of a forward-thinking approach with our policy as well in AI Scribes. Our policy, so we do favor streaming AI scribes because of the decreased risk of not saving an audio recording. And we are moving forward with a knowledgeable implied consent, given that we've gone through all of the same cybersecurity and privacy considerations that we would with an EMR or any of the other dictation tools. I can't imagine us asking our providers if it's okay to chart in an EMR every time a patient comes into the primary care delivery. We happy to talk about our policy more in question period, but we have taken a bit of reducing that recording and retention, so there's clarity and details online about that. Another thing that I think is really important to talk about is where AI is at, and AI requires human in the loop, real-time clinical validation at this point in time. Our policy speaks to providers are the most responsible for their chart in every event and must always review, edit, and finalize AI Scribe outputs to ensure patient records are accurate, complete, and contextually appropriate for the care. So leaving that liability and responsibility with our clinicians. Before I move into the next spot, which was maybe the most important part, I had actually received a clinical statement from one of our primary care partners, and I love that this quote starts with PS because it means that we were collaborating with her on something else, so we're actually engaging our clinicians. But PS, well done on the AI Scribe program. It is a game changer. The best feature, the summary of every visit I am sending to patients. Imagine being able to send it to them through your Health NS in the future, which is our patient-facing engagement platform. I'm really thankful to the Canada Health Infoway team, Abby, Krista, Edwin, Selma, Colleen, Valerie, Morag. They're very forward-thinking in this, and again, AI Scribe's here to stay, and frankly, old news at this point. Like, where does AI Scribe go next, and what does it unlock? And I wanted to take a pause and talk about the future of primary care in this one, because that's in the title. If I imagine a world where you walk into your primary care provider's office and you go in the clinic room and there's a big screen on the wall like this that has some iteration of your international patient summary in the future, and you're working through your history, your context, your conversation with your primary care provider in real time, transparently. Everything, because ambient listening's well and alive in the future world, is listening, picking up, and identifying. I think that's where we're going, and I think we're gonna have patients really as true partners in our future world. Some of the steps in that roadmap, as I said, we're there with the implementation of primary care, AI Scribe, that's happening, we're on the right track. The next step is extracting those discrete data elements, which I think is really exciting. I can't imagine having to go and try and change the mind of the clinician in Niels Harbor and rural Nova Scotia and tell them how to match the FHIR repo standard of discrete data elements, but AI Scribe's the biggest change management tool that we can leverage to get us there without ever having to talk to the doctor and get their clinical validation of those discrete data elements in real time at the point of care. The other thing that unlocks, and before I go into the next part, I think it's a naive, the futurist to me thinks it's naive for me to pretend to know where AI will be once we've nailed the discrete data elements. This is a rapidly evolving space, and I think we need to continuously learn. But some signals that might be, it would be the agentic workflows and the automation. So think about on that screen, at the end of the consultation, we're seeing a primary care provider and the referral to specialists completely filled out based on the conversation and the historical context, and we're just working through it with the patient. Patients seeing us approve that clinically in real time. I also think about the testing and referrals, but maybe a referral to social care if we're living in the future. These are the types of things we can do. And then further, we can go, I'm French, that's not me, clinical decision support. So recording the trends, identifying patient history, being prompted by the AI, that is the future that we're going to, and that is the potential that we have, in my opinion, with AI Scribe. So AI Scribe's fantastic. I'm super, super excited. We are seeing exceptionally promising results, but it's just the start, and we're here, and it's done. Let's get excited about the future and where we're going. The last thing that I would do or ask the table, and before we move into the questions, I hand it over to Rita, is a call to action for everyone to question everything right now. Think about it. Don't let it stop you. Ensure that our AI is use case driven and clinically validated at the source of truth, and we're thinking about the clinicians entirely. And be relentlessly curious, because I think this is all coming sooner than we think, and I don't think we even know what is coming. Thank you, everyone.
Wow. Thank you, Ryan, and thank you to all of our speakers for your insightful, thought-provoking, downright inspiring presentations. So what we've heard today is that initiatives like the AI Scribe program are templates for how Canada can successfully implement innovation at scale. When we bring together leadership, jurisdictional collaboration, vendor innovation, and clinical engagement, we can deliver meaningful results even within short time frames and limited resources. We've also heard how AI tools like scribes can play an important role in improving clinician experience, as well as the accuracy and usability of health information that drives patient care. So, and with that, let's open it up to some questions from the audience. We have 5 minutes, okay. Hi there.
This isn't working, is it? Can you hear me now? Okay, sorry. So I'm one of the patient partners. I'll be doing one of the concurrent sessions for this. And I think a lot of the things that are discussed are fantastic, really. I'm very impressed by a lot of them. But I'd also like to sort of caution, especially the last speaker, you're talking about going into your doctor's office and having your entire medical history on there, right? What happens when your appointment with last time was because you were just raped? I really think that you need to be reconsidering this idea of having everything on screen always. I think that having them this large is going to be very, very overwhelming, even if it's just stuff like, your weight is too high. I really think that if you're doing things, it needs to be on a bit more of a smaller, more intimate, private kind of presentation. I mean, the ideas are great, really, and I'm very much a fan of all of them, but I do just want you to sort of reconsider the presentation of them in your doctor's office. The other thing is making sure that doctors aren't going, or all clinicians aren't going to continually second guess themselves because the AI doesn't suggest something. So you need to have some kind of education saying, you know what, yes, this is a tool, but it's only a tool. You need to consider, you need to still use your clinician's judgment.
Thank you.
And really, this isn't a complaint, I promise. I just really do want to consider how these things might actually work.
Yeah, I would completely agree, and I think that's where, round of applause for that, for sure. I would completely agree, and I think that's where we need to iterate and have the clinicians and patient partners within all of those developments. Completely agree also on the IPS considerations on some of these things should be more lighter touch and maybe not that readily available. Absolutely, completely agree. Absolutely.
Okay, thank you. We have another question.
Hi, Bev Zwicker. I am the Nova Scotia Pharmacy Regulator. And Ryan, I loved your presentation, and building on that really important and really critically important feedback that we just received, and building on that. I am curious about if we're doing the upstream work of making sure that we are involving everyone that needs to be involved in true system transformation before we build the infrastructure to entrench the old system again. That's a real risk that we have. Now in Nova Scotia, I know, Ryan, we didn't talk about here, actually, we are, CHI is sponsoring AI Scribe pilot for pharmacies. And in pharmacies, we have community pharmacy primary care clinics that are extremely successful in all the quintuple aims. And just as a thought, how are we and when are we having the conversations about a primary care system that is designed for today and into the future that includes patients, and not just that patients are our partners, but that we are their partners, that truly is a patient-centered system. Because I think anyone who's looking ahead 5 years, I'm patient. It's not even patient. Individuals seeking. And how do we make sure that this system that we're building isn't just entrenching the old system? Because we can see how that isn't necessarily going to align well. I think, Ryan, what you described is a patient-centered system. I mean, there's certainly tweaks, but that vision.
Okay, thanks. Who wants to? Rashaad?
Yeah, so, no, it's a fantastic comment. And I think, it gives us pause reflecting on the presentations that were given around how technology is intended to augment good policy relating to the healthcare system. In this case, primary care. Primary care is the foundation of any high-performing healthcare system right around the world. There's tons of research to support that. There are lots of individuals across the country who are doing excellent work in this space. The Our Care program is one example. Dr. Kiran, Dr. Philpott, many others who are all involved in advancing the idea that primary care is more than just a family doctor's office. That's sort of a model that was decades old and is evolving into team-based care, into patient-based neighborhoods, medical neighborhoods. And these technologies are intended to make those models come to life, including clinicians of all backgrounds with patients at the center. And so I would see us, having the vision that Ryan presented is a very interesting one and engaging. And we're hearing it, around the world from all sorts of folks in AI and healthcare, but it's going to take a long time to get there and to implement that properly, even as fast as AI is moving. We have to put guardrails around it. We have to build it into build it into and support strong policy around primary care in particular and healthcare in general. And congratulations on the Clinician Innovation Grant.
Thanks, Rashaad.
Thanks. And if I could just follow up really quickly, just to say, yes, and let's have the conversations, because I know they're not happening yet. So I'm so excited for the opportunity. So let's have the
We
conversation.
love the excitement. Great. Okay, we have time for one more question. I think you were next, right in the middle.
Hi, I'm Wayne Samuels. I oversee MediCenters Canada. We operate primary care clinics, actually, on behalf of physicians. We're part of Medivy, Atlantic-based healthcare organization. Love AI Scribe. We're a partner in the program. Doctors are super excited about it. My question is that how do you get to the rest of the primary care physicians? So we're talking about 10,000 physicians that have signed up right now. There's probably 30 to 50,000 across Canada. In order for this to really have impact, you got to get to those. I know within our organization, we had about the same stats, 30%, no problem, signed up, they were already using it. We actually did a pilot a couple of years ago, so they were super excited, they're in it, they're using it all the time, but it takes hours to get to some of these docs. And we are trying to make sure we get every single doc, to use it, who wants to use it. And sometimes you just need to sit with them and sort of do that change management. You talked in Quebec about how you had the one program where you work with doctors. Nova Scotia, you own 50% of the clinics. You can sort of do that like we do it. But so much of primary care is individual one-off clinics. And what is the plan to actually extend this so we can get these benefits, not just to Scribe, but all those higher level benefits that we talked about that we know is going to be the future and help these docs and these patients out?
I'm happy to take it. I think, so going back to some of my Innovation Hub days when we founded that model, I think there are early adopters and then I think there are laggers. Like that's a reality of the world and we have to continue to develop and progress through that and share and communicate and build the guardrails around this. What I would say, I have a great clinician example of implementing a patient engagement. They actually asked me for a demo because they heard from a colleague that they should do that. He yelled me out of the room and said we should build this ourselves. We should not be having private partnerships. This is ridiculous. You're an engineer. You can figure this out. I left. A month later, I got a one-line email from that clinician and said, I'd like to purchase the product today, please. And we hadn't engaged. But the reality is that some people are not there right away, and we need to keep developing and partnering with clinical champions that are there, get it right, and then work to expand that adoption. And I think AI Scribe's just another great example of that. Once they see the benefit, that's going to amplify, and we're already seeing that amplification. Like it was 40% adopted in our early signals in Nova Scotia prior to the AI Scribe program that Infoway launched.
I was going to add very shortly, if you heard my presentation, that I believe the intent was awesome to get the ball rolling, but I think the ball has rolled now. And I don't think it's especially in particular with doctors who are independent contractors, at some point, there's a limit to having a program specifically for them to be able to get themselves better organized I believe that's where I honestly think that this round is enough for Quebec to have created that critical mass, and now they're going to share the federations are going to share that between them, and it should be enough. And some of them will never. Like I read the Legis, my EMRs, I still have 20% doctors are not an EMR, and if these aren't on EMR, I'm not going to get them on. So. There's laggards. I respect those who are laggards. I respect those reasons. I'm not sure an additional program for a second layer or a third layer. I strongly believe that this was great enough to create that critical mass, and now we have to look at other areas in the health ecosystem.
So respectfully, all I'll say is that I think that depends on exactly what the outlook is, and whether that's provincial or whether that's Infoway's output. Again, having seen the benefits of these and understanding how far they extend, if the alternative is doctors and you just say, well, it's up to you guys, you're private contractors, you can stay, but we're seeing them burning out. We're seeing them leaving primary care. We know this is a huge tool for that. And so I really do think that if provinces, if the country wants to improve primary care, wants to increase attachment, wants to do that, we have to think about what that cost value is, because it's expensive. It takes a lot of money and a lot of time, and it's just people time to go and sit with those doctors. But if we think that benefit's there, and again, everybody will have their own cost benefit, I think you really have to think about, okay, how do you get that next level of groups? how much is it going to cost, but how much benefit it's going to have if you don't lose that 45, 50-year-old doctor who's got 15, 20 years of practice left and has a panel of 2,000 patients, but just can't handle it anymore. So, I think everybody is going to make their own choice, but I'll argue that make that investment. This is the critical piece. And as we talked about, it's the base technology that's going to enable all kinds of future technologies, referrals, billing improvement, those kinds of pieces. And if we think that this is critical for primary care, then I think we have to think about, we talked about you don't have enough money to fund the present, but this is the money that's going to fund the future.
I'll be happy to take that conversation off. So I always accept a challenge to my idea. No, but it's true. I mean, maybe there's a point I haven't looked at it properly. I'll be happy to discuss offline.
All right.
Also happy to connect. Wayne, I've got some ideas on that.
All right. Thank you to all of our panelists, and thank you to all of you for joining us today.